Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing disorders that affect the veins in our bodies. Arteries, the other major blood vessels, usually get the lion's share of attention, but veins are important too. And today we'll explore why that is and talk about contemporary approaches to an array of problems that can interfere with veins' normal function. My guest is my colleague, Dr. Jennifer Svahn. Dr. Svahn is a vascular surgeon specializing in veins and leads Northwell's Venous Surgery program in Manhattan. She's also an assistant professor of surgery at the Zucker School of Medicine, and I'm delighted to have her on the show. Jennifer, welcome to Well Said.
Thank you. I'm so happy to be here and have the opportunity to speak with you.
I can't let the opportunity pass without first asking you how you've been managing during what has now been an extraordinary 2 years of a global pandemic.
I appreciate your asking. It's been a long 2 years, obviously, for me, as it has been for everyone else. But I'm healthy. My family's healthy. My boys are back at school in college. And I'm able to take care of my patients, which I wasn't able to do for a few months. So I'm happy to be on this side of the pandemic and able to be a part of Northwell's efforts to really combat COVID.
Terrific. Well, I'm glad you're well and that your family's holding up as well. So to get started, let's talk a little bit about anatomy. I mentioned veins and arteries in my little intro. So let's get down to the very basic stuff. So what is a vein and how are veins different from the other blood vessels in our bodies?
People use the words vein and artery oftentimes interchangeably. And it's, of course, important to start right at the beginning and talk about what they are and how they're different. So veins are thin-walled tubes. They range from very, very small microvessels to extremely large tubes. They form a very complex network of channels that are ultimately all connected throughout the entire body. And their primary function is to bring blood back from the extremities, the arms and legs, various tissues, and all the organs in our body, and bring that blood back to the lungs and heart so that the blood can pick up oxygen again. Most veins rely also on the normal function of thin valves that are inside. And these valves help us to keep our venous blood moving back in the right direction towards the heart, which is oftentimes against that strong pull of gravity. And the reason I mention the valves in this little introduction to what veins are is that it's very, very important when we talk later on about some of the most common problems with veins. And we'll talk again about valves and what their central role is in that. So while veins often do run right alongside the arteries when we look at the anatomy inside the body, they're very, very different. Arteries are those thick-walled, more muscular tubes that pump as the heart pumps, and they work to bring oxygen, bright red blood, away from the heart to all the organs, tissues, arms, and legs, so that all that good oxygen and nutrients can be delivered. And then out that blood goes through the veins and back to get some more oxygen on it. That's primarily how I would describe it.
That's a great basis for the rest of our conversation. So just to summarize, the arteries are taking blood away from the heart, veins are bringing blood back to the heart, and they often, as you say, run in pairs or in parallel tracks.
Exactly, yes.
I suspect that most of our listeners are familiar with problems that often affect the arteries, the tubes, as you say, that carry oxygenated blood away from the heart to the rest of the body. And some of those problems are strokes and heart attacks and organ or limb damage from poor circulation, those are generally arterial problems. What kind of problems do people develop with their veins?
We don't focus on all the peripheral arterial disease, the things that you mentioned, and the things that you take care of as a cardiologist. The veins in the body are not really affected by things like diabetes and smoking and high blood pressure or high cholesterol. The two primary pathways of problems with veins really have to do with either obstruction to flow, which means a clotting off or a closing off of the opening. So we get blood clots in the deep veins, in the superficial veins, and then nothing can flow through that pipe because it's clogged off. Or we have a vessel that's not clogged off, but those valves that I mentioned before aren't working. So instead of having a nice trapdoor mechanism inside that tube to close and help keep the blood moving back against gravity, back up the body to the heart and lungs again, those valves become floppy. So we get all this backward flow of blood, and that's called venous reflux or venous insufficiency. And oftentimes we see patients who have both things going on, both a clotting problem, so the tube is clogged up, or a reflux problem where it's open, but it's moving in the wrong direction. And all of that together creates an elevated pressure in the whole venous system. Now, people understand what it means to say hypertension or high blood pressure, and usually we're talking about the arteries. But the venous system can also have high blood pressure, even in a patient who doesn't have artery high blood pressure. So that venous high blood pressure or venous hypertension is ultimately at the very end, that's the problem that creates all the symptoms and physical exam problems and what ultimately drives patients in to see someone like me who specializes in venous disease.
That's a really nice framework for me to ask you a few more questions. So you said there were these two kind of cardinal problems with veins, obstruction and the malfunction of the valves. Let me just focus a little bit on the obstruction issue for a second. You mentioned clotting a couple of times. Is that the only kind of basis for obstructing a vein, or are there other things that can occasionally obstruct a vein?
That's the far most common scenario. There are other situations which are less common where there is a narrowing or a compression of the vessel. So effectively that opening, I like to tell people that I see to think of it as a straw. And you can look down the barrel of a straw and you can see that that straw is open. But if you fill the middle of that straw with sand or mud, you can't squish it anymore. That's what a blood clot is like inside a vein. But you could also have that straw and you could put a heavy rock on the outside of it or squeeze it with your fingers. So you can get a compression or a narrowing from something outside the vein, squeezing it closed. So effectively that opening is also gone. And we see that sometimes with, thankfully, less common things like tumors, bony structures, even muscular structures that will compress, sometimes even ribs in the upper chest will compress some of the big veins to the arms. So yes, while clotting is the number one cause, there can be external or outside compression. But they're both doing the same thing. They're creating a scenario where that opening is now closed.
Yeah, and are these problems specific to veins in particular locations? In other words, does where a vein happens to be in your body affect the likelihood of one or both of these kinds of problems arising?
You know, like all things in medicine and when we evaluate patients, there's so many factors that we're looking at and considering all at the same time. So I'll try to ferret them out separately, but the truth is that they're all being considered in unison. When patients come in with, let's say, lower leg swelling and a distribution of dilated veins, we call varicose veins, bulging out of the skin there, depending on the location of those veins, that'll give me a good clue as to what's going on and where the problem is. If a patient comes in and the entire leg is swollen from the groin all the way down, or even some swelling at the lower abdominal area, that tells me that the problem's probably higher up in the pelvis or the abdominal area, and that gives me a clue about what am I looking for. Are there other things that point to maybe there's a tumor? Maybe there's a strange phenomenon where one of the arteries in a woman actually compresses the left leg vein that runs underneath it. Maybe the patient's had special catheters or other medical work done where the vessels were, manipulated, had catheters put in there, and then there's been some local trauma. That'll give me an idea about what might have happened and what's going on when I do further investigation.
So that leads me to another question, which is, are there things about a patient or their experience, their medical problems that predispose individuals to having these sort of problems with either blood clots or compression of their veins or the valves not working? Why does this affect some people and not others?
When we think about the things that put people most at risk, number one through 10 probably is a somewhere along the line there's a genetic component. So you inherited from someone in your family, mom or dad, or maybe grandma or grandpa, or maybe even a couple generations ago, but somewhere in your genetic blueprint is something that makes your vessels more likely to become thin-walled, weaker, and dilate. So the genetic tendency is absolutely primary. And, of course, we can't control that.
That dilation, is that what leads to the valves not working? Is that what you're saying?
So dilation can lead to the valves not working because that tubular structure, the vein, becomes so big and floppy that the valve leaflets no longer touch each other when they close. So you just have a floppy, inadequate valve. Like in any other mechanical thing, like an engine or some plumbing, where there may be a flap valve. If that mechanical structure, in this case we're talking about a vein, becomes so big that those flap doors of the valve can't reach each other anymore, then you no longer have an adequate valve. But other things can cause problems with valve function. When we have clotting inside the vein, it sets up a very significant inflammatory state. And what that means is a situation where the body is undergoing a lot of rapid, significant change at a very, granular, we say, or basic level. And there's a lot of chemicals, mediators, and all sorts of things going on that creates a stiffening and a thickening and a hardening and a scarring down of those vessels. So, we say phlebitis, and the reason it's important to know that word is that phleb, anything phleb refers to vein. It's a Latin base for vein, and itis means inflamed. So phlebitis means an inflamed vein. And when we have phlebitis, inflamed veins, the valves are going to be affected because they also get inflamed. So valvular dysfunction can be because of clotting. It can be because of dilation, and the valves simply just don't touch each other anymore. And then, of course, it can be a combination of the two.
And so you said that 1 through 10 has to do with some sort of genetic predisposition. So what's like 11, 12, and 13?
Okay, and then let's move on down the list. So female gender makes you more likely to have any one of these venous abnormalities. That said, however, I have many, many patients who are men, and if you look across the whole of the population, anywhere from 25 to 40% of women will have some presentation of venous disease, whether it's just symptoms or some severe complication. And that gets more likely as the woman gets older. But men also, anywhere in the range from 10 to 20% of men, more likely as the men get older, will also have complications or have some form of venous disease. So that said, this is a very, very common problem for both men and women and across the ages, more common as you get older. Getting back to our risk factors, so female gender, yes, it puts you at greater risk. Obesity puts you at greater risk, and that has to do with increase in pressures inside the belly with obesity, some decreased mobility or moving around with obesity, because we know that sitting and standing still for very long periods of time without movement is another risk factor. And then things like inherited, meaning you're born with it, clotting disorders, so something that makes you more likely to clot. Again, you either got something in your genetic pool that makes that true for you, or maybe you have an underlying cancer, and sometimes that will present to us with blood clotting. Those are really the most significant risk factors. Depending on what the risk factor is or risk factors, that's going to determine exactly what kind of venous disease, what the symptoms are, and what it looks like physically.
Yeah, well, that's what I wanted to get to next. I was struck by how large the percentage of people you said are affected by venous disease. And so I wanted to have you describe for our listeners what it is that individuals who are affected experience. What do they feel? What do they have? How do they know they have it? What does it look like from their perspective?
The most common patient with venous disease will have some sense of a feeling of heaviness or aching in the legs. And I'll focus on the legs here because that's the most common scenario. The arms can be affected, but we'll focus on the legs just because that's by far and away the most likely situation. So the patients may complain of heaviness, aching, swelling in the legs, symptoms that get worse as the day goes along, as they've been standing up out of bed or sitting all day, a feeling of restlessness, even itching. Those are all symptoms that the patient may suffer with that tend to get better after they've been asleep at night with the legs up. They get up in the morning and, hey, my legs don't feel too bad. And then as the day goes on, the symptoms get progressively worse. Then the disease will progress potentially from just symptoms to symptoms and skin changes. And the typical skin changes are a darkening or a browning, thickening of the skin, usually at the very lower part of the leg, particularly around the ankle region. And finally, when we get to the more advanced stages of venous disease, that dark, thick skin change can actually break open into open ulcers. And the open wounds or the open ulcers will typically, again, occur at the lowest part of the leg where the pressure is greatest, at the middle ankle region, and even at the outer ankle region, depending on what veins are involved. And that just is a representation of how the disease slowly progresses over time. And then ultimately, and we call that a stage 6 venous disease, when the patient is really struggling with these open wounds on their leg.
What causes that darkening of the skin?
We call it a hemosiderin deposition, or the pigments of red blood cells, the hemosiderin, leaves a brownish staining on the skin. Just like blood, if you cut yourself and you bleed a little bit on a white shirt and then you wash it, it's going to be left with a little bit of a brownish stain. It's that same brownish freckle kind of discoloration, and that's called hemosiderin staining, and it's directly related to the pigments of red blood cells.
And that pigment gets into the skin because of the increased pressure in the veins? Okay.
Exactly, because of the venous hypertension and the compromise or the worsening of all the physics behind all of this is fascinating, and that's another lecture. But once you change the pressure and what happens normally, and we alter that scenario, we start to see movement of fluids and blood across vessel walls into the other tissues, and that's when the skin changes and even changes in the fat, and the staining of the skin develops.
And that's what causes the swelling too, right?
And that causes the swelling too, absolutely.
When somebody comes to you with those kinds of complaints or those kinds of concerns, what do you do as somebody specializing in this area to evaluate the state of the functioning of their veins?
This is what a typical evaluation would look like. And it's important to remember that the very most important part of the assessment starts with getting a good history from the patient. What is the history of their symptoms? When did it start? How did it evolve over time? Is it associated with pregnancies? Is there a family history? Did the patient undergo some other medical instrumentation or procedures? Have they had an underlying malignancy? What are their other medical problems? Are they on medications? Have they had recent surgeries, orthopedic surgery, gynecologic pelvic surgery? These are all risk factors for venous problems. Do they have the family history? Again, very, very important. Has there been any clotting in them in the past or their family? Have they had a long airplane flight recently? Why? These are risk factors for clotting. What do they do for work? What is their normal mobility status? So the first most important thing always is a good history. And if you're a healthcare person, doctor, nurse, or whomever is evaluating you, isn't starting with a really good detailed history, you're not off to a great start, because so much important information comes from that. Then we move on, right? Okay, that's my father's an internist, so my medical dad's going to be proud of me.
I'm proud of you too. That's great. Okay.
All right, so we start with a very detailed history. Then we can move on to our physical exam, because we want, again, as I mentioned before, the way that the disease looks to us will tell us a lot about what's going on underneath, and also what are the most likely causes, and of course, then most appropriate treatment. So I look for signs of swelling. Does it really look like vein swelling to me, or does it look like something different? Does it maybe look like swelling related to a lymphatic problem? Or does it look like swelling related to a different kind of adipose problem called lipedema? Different disease also in women, and they can be very confusing, and they can overlap. Does it look like someone who maybe doesn't have a venous problem at all, but are they in congestive heart failure and they're coming to me with legs that are edematous, but the real problem is in their heart or their liver or their kidneys? So again, good surgeons are also good doctors and good medical doctors to some extent. So we need to be able to ferret out what's really the cause of the swelling, and is this the correct diagnosis to start with. So presuming that that's true, and it looks to me like a vein problem, and I'm looking for varicose veins, I'm looking at the quality of the skin. Are there ulcers? Are the arteries intact? Do they have good arteries? Or is there an artery problem underneath all of this? Does it really look like a vein ulcer, or does it actually look like an artery ulcer? Very different disease, and it'll look different on physical exam. And then from there, we go into our vascular lab, which is in the office, and we have, as most labs will have, a registered vascular technician who has a very particular skill set in using the ultrasound machine, same kind of ultrasound we use when we look at pregnant ladies' bellies. We use sound waves to give us images of the legs, and also to show us some flow patterns in the veins. And in that, I'm looking at the deep veins, the superficial veins. I'm looking for the two things I talked about at the beginning. Is there obstruction, and or is there reflux? So does it look like something clotted off sometime in the past, either recently or long ago? Do those veins look like the valves look like they're working or not? Do I see blood flow moving in a backward direction? And if so, from where? Does it seem like there might be a problem higher up in the belly area, or is it really limited to just in the leg area? And all of that information is being processed all at once to give me an idea about what's really going on. And then from there, I can decide what the severity is of the problem and where I need to start with what kind of treatment, whether it's a non-invasive treatment or we start talking about actual more invasive procedures.
Yeah, so before we pivot to treatment, I just want to summarize briefly what you said, because I think you gave a great explanation, but it really boils down to talking to the patient carefully, looking at the patient carefully, and then maybe doing some ultrasound examinations to get some objective evidence of what's going on in the veins.
That's it, 100%.
You know, I'm struck also by what you said earlier in our conversation about the final common pathway of most of these problems being an elevated pressure in the veins. You know, I'm a cardiologist, and I treat a lot of people with elevated pressure in their arteries, and we have tons of medication to lower people's blood pressure and treat their hypertension. Are there medications that you use that can have an analogous effect on lowering the pressure in people's veins?
So unlike the cause of high blood pressure, at least sometimes in arteries, the veins are not muscular structures. They're thin-walled tubes without a muscular component. So we don't have medications that'll work directly on the vein vessel itself in terms of allowing it to relax or contract. So we can't control the venous pressure by directly acting on the vessel. So we have to aim our treatment at the hypertension, at fixing the root cause. So we need to address why is there reflux, and can I alleviate that and make that better? And if I can, then I'm going to help lower the pressure that way. Is there obstruction, and is that a cause of an elevated pressure? And if there is there a way for me to get around that or alleviate that or support the body until it can form its own pathways around that? So we don't have the same sort of, I would say, vasoactive drugs, meaning drugs that work directly on the vein itself to control its contraction or dilation. We have to identify and fix the underlying problem.
Which sounds more like a mechanical issue or a surgical kind of intervention.
Oftentimes, although the first ways to control hypertension can be things as simple as, hey, get up, move, walk, squeeze your calf muscles. If you're able, if you're not immobilized, which unfortunately some people are and they can't get out of bed and they're not capable of walking, just using and activating that muscle pump, because the calf muscles, the gastrocnemius and the soleus, the calf muscles are very, very powerful contractors and will literally squeeze that blood up out of the lower leg, which is why when we don't move and we're sitting and standing for prolonged periods and we're not squeezing that calf muscle, we lose that muscle pump. So a way of decreasing venous pressure can be as simple as walking, doing calf raises, calf pumps, wearing support hose. Wearing support hose will help create a situation where there's a little bit of extra compression, like a hug around the whole lower leg, which helps to diminish the pressure in the veins and keep fluid from accumulating. Elevating the legs above your bed. So there are, if you go home and you want to lay on your back and get your legs up the wall, that's a very effective way of, at least during that period of time, getting the venous pressure back down. Sleeping with a pillow under your heel, that can help. So those are all non-invasive tools that, particularly in the early stages of venous disease or venous hypertension, can really be very effective at lowering the pressure in the legs. Of course, when the disease gets more severe, those measures may not be enough, and then we have to talk about some more significant ways of actually closing off those bad veins, the ones that aren't working.
What does that entail?
When we see significant disease in the veins that are closer to the surface of the skin, called the superficial veins, those veins can just be removed. Now, back in the day, we used to go to the operating room, put people to sleep, put incisions in their legs, put wires up, and literally pull that whole vein out, called stripping and ligation. Very effective, but it required a trip to the operating room, and it had its own not feeling so great for a while blues after the procedure. But now we can effectively do that without ripping the vein out of the body. And how's that? I can remove it effectively by just closing it. So I can put a catheter in the vein in my office under local anesthesia using an ultrasound to see what I'm doing. And I can use the heat at the tip of the laser to close that vessel. And by closing the vessel, I've effectively removed it from your body without actually having to rip it out. And those are called ablation techniques.
Let me just ask you the obvious question. If you close off that vein, where's the blood go?
When we do these ablation techniques, we're using it to treat the superficial veins. You don't need them. There's all sorts of adequate veins throughout your whole body, including the whole deep system. And other connecting vessels. So the venous system is a very beautiful, redundant, and complicated system. And all we're doing is removing the one superficial vein that we've identified as causing your problem. The deep veins cannot be closed and cannot be removed, even if they're not in great shape, because then you have absolutely no way to drain your leg, and and that's just not compatible with the health of the leg. You'll end up with a big, huge, swollen extremity.
You can zap these superficial veins, close them off. What other tricks do you have up your sleeve?
So the other tricks I have, we mentioned all the things you can do, including stockings, and now the thermal ablation. I can also put chemicals in the vein, whether it's a form of sclerotherapy, where I put a foam chemical agent inside the vein that irritates the vessel wall just enough to cause it to close and scar down. The end game is the same. That vessel is no longer open, and there no longer is effectively a part of the circulation. And eventually, if you go back and look at it over time, you just see a scarred up string where that vessel used to be. And then finally, I can do local stripping of vessels, whether they're the side branch veins or even short segments of the main vein that goes down the length of the leg. Those can be removed, and that's called a phlebectomy. So that's more of a limited surgical procedure with small incisions. But I haven't had to take a patient to the operating room to do the real big old stripping in it's probably 6 years now, because all of these other office-based measures are so effective that it's a very unusual scenario where you have to be in the operating room to do something like this.
Well, look, I want to thank you for sharing your expertise and really taking us through the whole anatomy to treatment conversation about veins today. One last question is, if people are interested in learning more, where can they go to get more information?
The American Venous Forum, which is one of our main specialty groups, fabulous, and has lots of information available for patients on the website. And the website is Vein Forum, which is VEINFORUM, one word, veinforum.org/patients/American Venous Forum. Great source of information. I send a lot of my patients there to read through things. And then I'm here. So I'm always a source of help. And I'm happy to talk to or see anyone who has any more questions.
Well, that's terrific. And thank you so much for sharing your expertise with us today.
Thank you, Ira. Happy to be here.
So my guest today has been Dr. Jennifer Svahn. She is a vascular surgeon specializing in venous disease and an assistant professor of surgery at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.